Okay, let's get started. Welcome back, everybody. It's been a few weeks off. We had a lot of big events on our Thursday designated biopsy conference time. We had the intercity fellowship debate that the National Kidney Foundation of Illinois puts on. That's always a lot of fun. We had our graduation the next Thursday, and then last Thursday, of course, it was New Fellows Day, July 1st. That's always a big day for all of us. But we're back. We will have this week, probably next week. The week off will be. The week after, that'll probably be off because the ASN board review course. Again, follow your emails, look at Twitter, and the announcements will all be there. I think after that, we'll try to be pretty steady because things will get back into full swing. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for the 8th of July, 2021. Today's CME activity code is 482924. These are being recorded and available on our YouTube channel. We encourage you to go there and subscribe. The case has been de-identified, and as usual, we have nothing to disclose about any involvement related to this case. Dr. Whittier is going to lead us in his case and discussion at the end. So, Bill, if you want to take over and tell us about your case.
Thanks, Roger. Yeah, and the winner of the debate.
Well, yeah, we did. Yeah, that's a slippery slope. We won, so yeah, we won this year, but that's not always every year. So
yeah, I wasn't going to announce it if we lost. I mean, but yeah, our star fellows did very, very well. Awesome and Raleigh were great up there, and in a weird debate format with Zoom, but they did just wonderfully. So we're really proud of them. We would be proud if they didn't win, but we're even more proud that they did. Okay, so let's get into the case. We've got a 24-year-old young East Asian woman who really had no past medical history. She's a graduate student and was minding her business when she noticed that her shoes weren't fitting. And then within days, it progressed to swelling above her knees. She actually went to the emergency room locally with her where she goes to school. And they did blood work, which was unavailable to me, but they never did a urine study, and they had sent her home on some Lasix. She returned a week later because her swelling wasn't getting away, and she told them that she had this, frothiness to her urine, and so they checked the urinalysis, and there it is. Her had 4+ protein. She had moderate blood and 10 to 14 red cells with significant albuminuria and proteinuria that you can see there. The creatinine was 0.8. Her albumin was 2.1. And she really didn't have any complaints except for this overall swelling, but she even felt that it was in her abdomen as well. She had no fevers, chills, pains, or other urinary habits except for the change in urinary habits except for the frothiness. She denied any over-the-counter medications, including NSAIDs, and she did not use any herbal supplements. Other than that, the rest of it was pretty unremarkable. She was a pretty healthy young girl. When they saw her there for the first time, her blood pressure was 98/60. Her weight was 135 pounds, and 3 months ago, she was 105 pounds. So she had put on 30 pounds in a short amount of time. In general, she's no acute distress, but she's very uncomfortable to the swelling. Cardiovascular was normal, her lungs were clear, but her abdomen was distended with a fluid wave, and she had 3+ edema, which went all the way up into her thighs and actually included her sacrum. She didn't have any joint synovitis, and she didn't have any rash. On physical exam, her sodium was 123, her K was 5.1, renal function was normal, her albumin was 1.4, and her LFTs were normal. Her total cholesterol was 461, with the LDL being 321 and HDL 92. Her CBC had a hemoglobin of 11.9, and then serologically, she was negative for ANA. She had mild hypocomplementemia. The reference range for C3 in our lab is 81. So she was at 76. Double-stranded DNA was normal, rheumatoid factor normal, ANCA negative. Hepatitis, PLA2R, SIP, and UIP were all negative. Her urinalysis, when it was repeated, still had the massive amount of proteinuria with 10 grams of albumin and 14 grams on the PC ratio. She still had moderate blood, 10 red cells, and did not have any casts. We had done duplex of renal veins as well as extremities without any evidence of a DVT. Her initial chest x-ray had this prominence at the left heart border that we thought might have been lymphadenopathy, so we got a CT of the chest, and that was unremarkable. It was just kind of an overcall read on the chest x-ray. And her renal ultrasound was normal sized kidneys with the left of 9 or almost 10 and the right of 10.6. No echogenicity, no hydronephrosis. And then she got a paracentesis with 2.5 liters off, and we did a percutaneous renal biopsy as well.
Great. Any follow-up questions for Dr. Whittier? Super. Well, I'm going to take a stab at this. Dr. Corbett's in France, and he's in a restaurant, so he has a little too much background noise. And Dr. Gashi's out of town, so let me take a stab at this. And I like if Pravir, if you could just keep the slide up there. I'm going to go through it the way I kind of look at these things when they're read to me. So, age isn't super helpful here. Or she's not really a kid or not really an adult. Well, she's an adult, but she's a young adult, and that may play into some diagnoses. But I don't think it's really very helpful here. But I see East Asian, and two big things come up to me: is IgA and lupus. Now that's not super strong, but I always used to say if you can't get the CPC from the first line in the New England Journal of Medicine CPC, then you're not going to get it. It's not quite like that here, but I form a very strong opinion very quickly. So even though I haven't, as I already know the whole story here, but as I'm looking at it, I'm thinking, maybe IgA, maybe there's an increased incidence of lupus, and we'll have to see it. And it's a young woman, so especially with lupus. And then who presented with sudden onset of swelling. So that's a very, very strong clinical indicator towards certain diagnoses. Of course, minimal change and some variants of focal sclerosis is kind of what you're thinking of. It's not something you would think of with IgA nephropathy. Certainly with lupus, I don't have a huge problem with that, but we'll get a better idea as we go along. She doesn't have any other symptoms to suggest lupus. She has no rash to suggest systemic symptoms of IgA. But we definitely see patients with class 5 lupus who don't have anything else in their story to suggest lupus. It'd be unusual for a proliferative lupus to not have something else, but we've definitely seen that. So I think lupus is still in there. IgA, I'm not really so thrilled about anymore, but we have to keep it in there, and that's why we do biopsies, because of course we don't know. Moving along, she's got a normal creatinine. 0.8 seems maybe a little high for a young woman, but it depends. Albumin's 2.1, so she's pretty low, and she's what's interesting here, she's got some red blood cells, and I think we'll come back to that and get some opinions on that as we go along here. But it kind of gets me personally, it gets me a little bit away from minimal change disease. And again, I think that's a point I want to discuss, because I don't know how strong or how relevant that is, or how reliable that is. But I tend not to think of it as having much blood. So I'm moving that a little bit away. But then I get back, and she's very nephrotic. A large part of it's albumin, may or may not be helpful, but certainly some strong glomerular disease going on there. And no other symptoms, as I said before, and she's probably not taking nonsteroidals, which is always in the differential of somebody with acute onset of nephrotic syndrome. Moving down, not much here, no drug use. Blood pressure's good. If it were high, I'd be thinking a little bit more like on the focal sclerosis spectrum, but it is normal. The fluid wave is interesting. She's got ascites. We find that later, even on ultrasound, and she has a large volume paracentesis. And I'll bring that up too, because personally, that doesn't get me anywhere. That doesn't help me one way or the other. But I can tell you, I haven't seen that very much with nephrotic syndrome. I've seen very nephrotic patients, but not to the point where they have that much ascites. But I'm being anecdotal, and I'll be curious about other people's opinions on this, and we'll go into all those things. What's next? 30 pounds is a lot of fluid. It really goes to the sudden onset of swelling, which is, when you start seeing this kind of acute, severe nephrotic syndrome onset with significant hypoalbuminemia, of course, minimal change disease is kind of what wants to scream out. We get to the sodium here, 123. I think that's pretty unusual to be that low in any patient with nephrotic syndrome, because you're retaining both salt and water, and generally that kind of keeps your sodium up. With the ascites, somehow it kind of fits to me. I don't know. I guess I think like a cirrhotic or something, but somehow it just doesn't bother me much with the ascites. But I think that's folly. Creatinine's a little bit better now. It's 0.7. Glucose is normal. She's not diabetic. Her albumin is lower now. It's 1.4. So she's severely nephrotic. We go through here, hemoglobin A1C, everything, but a cholesterol's 461. And we've had discussions in this group many times about the potential relevance of significant hyperlipidemia as pointing towards the disease, and maybe having a little more specificity and sense, well, I should say specificity for minimal change disease. Hemoglobin's 11.9, a little anemic, maybe a little surprised, maybe for somebody that came on this acute, applies to me more of a chronic disease, inflammatory disease, but not enough to change. And then we get to the serologies. ANA is negative, but like I said, you can have lupus membranous without serologic evidence of lupus, at least initially. The complements are a little bit low. We have this whole differential diagnosis of hypocomplementemic GN, but 76 when the normal is 84 and 12 when I think the normal is 14 or something. I don't get that excited about it. I don't know. We lose a lot of protein in nephrotic syndrome. I don't know if complements can drop a little bit. I've not seen that, but it kind of occurred to me as a potential explanation. But I would not go down the hypocomplementemic rabbit hole in this case, based on that level of C3 and C4, even though they're technically low. I don't really make much of that. Nothing else here for once we actually have a PLA2R. It's not pending to throw us off. So at least that's negative. Doesn't mean she doesn't have membranous. Something I really haven't talked about yet with hematuria and a young person. But at least it's negative here. Urinalysis is really nothing. It still has the blood. You can see just how nephrotic she is, with a large percent of it being albumin. And really nothing else here. The chest x-ray kind of teased us for a second. Maybe there's something going on with lymphadenopathy. You always worry about in a young person with nephrotic syndrome having a lymphoma, but it turns out there's nothing there. So, what am I left with? I'm left with maybe one good diagnosis and some red herrings, or I'm off. To me, it gets down to as I said, the story, but the story is not the first half of the sentence. It's the full sentence, and it's sudden onset of swelling, 30 pounds. She has severe hypoalbuminemia, severe nephrotic syndrome, and very high hyperlipidemia. So I really have to put minimal change, my first, diagnosis, maybe a focal sclerosis as a second. But it could always be a membranous or something else, or lupus membranous. But I'm going with minimal change disease. Pravir, what do you think?
No, I completely agree. I think, putting the weight on the presentation and her overall how nephrotic she is, I think minimal change is number one for me. Now, in terms of the demographics of East Asian, I think IgA was brought up. I know there is a subtype with IgA that has kind of diffuse podocytopathy, and there's a kind of I guess you can call it a variant IgA with minimal change disease kind of superimposed. And maybe the blood could be explained with that. But I think at the pathological or the histological, I should say, level, you'll see diffuse podocytopathy, and we'll see what the immunofluorescence shows. I think lupus I would put above FSGS for me, just basing on, again, that first line, young woman and very mild hypocomplementemia, even though ANA is negative. So I would put minimal change 1, lupus 2, and maybe lupus podocytopathy or membranous, because again, she has otherwise, negative ANA. Her anti-double-stranded DNA, I believe that's within the equivocal range of our lab, and so so I think that still has to be considered in any young patient coming in with AKI or proteinuria. And then I would membranous 3 for me. It doesn't fit the typical 5th or 6th decade, but we've seen, those are typical. Of course, there's going to be a range of older and younger people, and it would fit. That would allow us to explain the blood a little more, as you mentioned, with minimal change. We don't really see that blood, and maybe that could be a membranous that would, although the presentation will be a little slower, I think that's still part of it. So I think I would put a minimal change, lupus, membranous, and then like I said, IgA. I don't think the IgA can explain the sudden onset unless she has one of these variants of kind of IgA with minimal change or diffuse podocytopathy that can present like this.
Yeah, the interesting thing about that, I'm glad you brought that up, is that, these patients that have IgA with diffuse foot process effacement that present very nephrotic. IgA is a very common disease that people can have. And how do we know that, what they really have? And maybe that's what she had. She's Asian, she's got some background IgA nephropathy, and she has minimal change. And I don't know how there is a way to tell that. Those patients typically would get treated with steroids and often get better. So, I'm really glad you brought that up. Sarah, we have a pediatric nephrologist. Sarah, are you with us? You can unmute yourself.
Can you hear me okay?
Yeah, great. Sarah,
Great.
can you elaborate a little bit on, since our number one diagnosis really is minimal change, but one of the big things that's throwing us off is this hematuria. And I know we've asked you this before. Um, how do you feel about blood and with minimal change disease? I mean, this is a disease that's minimal change. It's foot process effacement. There's no proliferation. There's really nothing else going on. How do you feel about that? Does it bother you the slightest bit?
Not at all. Like in kids, we see it all the time. I think the literature cites about 20 to 30% of kids with microscopic hematuria, gross hematuria obviously being really abnormal, but microscopic hematuria is actually pretty common. And I haven't been able to find a great reason. I don't know if they've actually looked at the basement membrane just to verify that some of these kids don't have the basement membrane that are obviously subclinical, and you just happen to see them. Because I don't recall necessarily the microscopic hematuria resolving, although we don't necessarily go look for it. We're obviously looking for the proteinuria. The other thing I was thinking about, the C3 being kind of soft and low. Of course, we see that on occasion, but I'm just wondering with this case with the hematuria, is it possible that she might be a history of an infectious glomerulonephritis that's resolving? Why did she not have gross hematuria, or why now is she nephrotic, not in the past? I'm not exactly sure, but that's the only other thing that kind of crossed my mind when I saw the collection of the acute onset of edema, as well as her overall presentation. That hyponatremia, though, is, as you brought up, pretty impressive. I think the lowest I've seen is like 129.
Do you what about the blood pressure? Would that rule out a post-infectious to you at all, or not really?
Not really. I mean,
Okay.
the post-infectious that we see that are AKI, I mean, it's malignant hypertension, and we don't. The symptoms are usually normal with minimal change disease. I'm just trying to figure out how can we have a nice story that explains all the different aspects of her presentation. I'm a little surprised with the weight gain that her blood pressure is that low.
Well, that's great. I know we've had biopsy conference for decades, and you've been here for, I don't know, one or two, but I know I always ask this, and I'm always surprised at your answer on the hematuria, and I never get used to it. I may never get used to it. Certainly as adults, when we see hematuria, we start thinking of some of the variants, maybe the mesangial cell variant of minimal change disease, and that kind of explains it, and often has a little bit of a different response rate and prognosis, et cetera. But maybe we're wrong. Maybe it's just that's what we see. Dick, what are your thoughts? What are your thoughts about the hematuria, Dick, and Dr. Gossick? And another question I have is about the ascites. Is it just me? I have not seen ascites in acute nephrotic syndrome. Unmute, Dick. You got to unmute.
Well, of course, in pediatric nephrology, ascites is quite common in minimal change disease. The younger the patient, the more prominent the ascites is. And in fact, in the pre-steroid era, superimposed pneumococcal peritonitis was a not uncommon cause of death in minimal change disease in the pediatric population. It is much less common in adults. I don't know exactly why. I don't have a good answer for that. And I agree with all the comments about hematuria. I don't think it has particular diagnostic significance in this case, and I can't explain where it's coming from, although I guess it would be helpful to know whether or not the red cells showed acanthocytotic change, or whether the features of the red cells in the urine suggested a glomerular rather than a tubular origin.
Great. Any other? I'm glad that I'm glad that the ascites. I just haven't missed it, and that is more common in kids. And that is an interesting distinction. I think it's time to take a look at the biopsy. So let's get the wheel ready here. Faraz.
New academic year, same wheel. Faraz, can you hear me?
Faraz is now a second-year fellow
Oh,
for a week.
Yeah, the wheel just loves him.
The wheel does love Faraz. Who he said.
Okay.
Can you hear me?
Yeah, you can hear. I'm going to share the screen and then I'm going to let you take over. Give me a second here.
Alrighty, so this is a Trichome Stain, low power. We've got 3 cores. Everything looks really well packed together. I don't see a lot of fibrosis or the blue stain. There's a couple little focal areas. I'd say like less than 5%, 10%
good.
at most.
Yep, very good. Looks like a good preserved kidney.
This is a higher power PAS stain. We've got 2 gloms. I'm not sure what this open area is. Is this the opening of the proximal tubule? possibly?
That's the hilum. So
hilum,
that's right where
okay.
the afferent and efferent arterioles are coming in.
Okay.
Yeah.
But the glom itself, it has good open capillary loops. I don't see, mesangial hypercellularity or expansion. And then this one, again, good open loops, no expansion or hypercellularity, obviously no crescents or necrosis or anything like that. And then the tubules have pretty good brush borders, is maybe a little bit of sloughing here. But all the other ones surrounding have good tubules. They're closely packed together. They don't look atrophic.
Yeah, and no interstitial infiltrates between the tubules either. Yeah. Okay. Good.
Higher power PAS. Yeah, this looks like a classic normal glom. I don't see, there's maybe 5 or 6 mesangial cells here that they're a little packed together, but outside of that, it looks pretty normal.
Yeah, in fact, one of those I could see is an endothelial nucleus. Another one is out on the outside, a podocyte. So that's just normal cellular normal cellularity for the glomerulus.
Okay.
I think it's worth mentioning the fact that 2 things came up in the differential diagnosis. One was IgA nephropathy, and the other was a mesangial variant. Although we're probably, I keep harping on the hematuria, which is probably wrong, but thinking about a mesangial variant of minimal change disease, if that's possible in this case, the point is we don't see mesangial hypercellularity. It doesn't completely rule those out, but it's worth mentioning since those were in the differential.
And then going back to the tubules, good brush borders.
Actually down in the lab, down at 6, 7 o'clock, where the air, I don't see brush borders on those tubules.
Oh yeah,
and the tubule right above it. Look at the, there's no brush border there.
Yeah.
And the epithelium's thinned out.
Okay, so there's a little bit of ATN.
Yeah, there is ATN.
Yeah, and
this one too. That's an artery. Yeah, that's an artery. Yeah. So there is some ATN, and then over around 9 o'clock, that tubule there is becoming atrophic. The one next
this
to
one?
it. Yeah.
Okay.
Look how thick the basement membrane is.
Yeah, the basement membrane's thickened, and the epithelium is thinned out.
Yeah. All right. So okay. Yeah. Go ahead.
So another high power PAS stain, normal glom, open capillary loops, normal mesangial cellularity.
How about down at 6 o'clock? Yeah. What is that region of the glomerulus?
Oh, this is the hilum.
Yeah.
Again.
Yeah.
And is this the proximal tubule?
Well, that'd be the distal tubule with the JG apparatus.
Oh, that's the JGA. Okay.
Yeah.
Okay.
So we don't see the origin of the proximal tubule. It'd be, up around 12 o'clock, but we'd have to cut deeper in the tissue to see it.
Oh, right. Okay. And then this tubule looks a little thinned out. Don't see, you know, there's a couple areas where you can see brush border, but outside of that, the brush border is lost. So there's a little bit of ATN and some of the surrounding tubules, but otherwise look okay.
Yeah, in fact, look at 11 o'clock. There's a perfectly preserved tubule. It's right above.
Yeah, right
yeah,
there,
there
right
you
there.
go. So all the tubules should be looking like that. So you can see, yeah, there is quite a bit of ATN in the tubules.
Surprising because their creatinine was normal. There was no granular casts on the UA. And then high power H&E, good capillary loops, no necrosis, no crescents or anything like that. Good mesangial cellularity, no expansion. And there's some sloughing off in the tubules here. I don't see an infiltrate or anything, you know, in the interstitium. Yeah, there's not much else.
Good.
Jones stain, high power. This would be looking for breaks in the basement membrane or spikes or holes. And I really don't see any of those.
Yeah, I agree with
I
you.
don't see any.
Yeah, the capillaries look intact. Yeah, no pathology.
And then high power PAS, looking at the tubules, there's actually, you know, a good amount of ATN here. This is one normal tubule. Let's see, there's more ATN here. This one's pretty thinned out. And already
some of
lost
those
its
are
border.
distal tubules where the nuclei are more tightly packed. Yeah.
Oh, okay.
Yeah. Okay. And then there's an arterial down at the bottom left. It's okay.
Down here.
Right there. There's an arterial without any hyalinosis. That looks normal.
Okay. Immunofluorescence for IgG is negative.
Yeah, IgG and everything else completely negative.
Okay. And this is you know, EM. We've got an RBC here. So this is the capillary space. This is the mesangium. And you know, this is you know, some podocyte foot process effacement. Pretty extensive all the way around, I'd say.
Yeah, so I mean, what are we left for to account for her nephrotic syndrome? What?
This would be minimal change then.
Yeah, exactly. Yeah, and so look down at the bottom right. There's another capillary, so you can see diffuse foot process effacement all throughout. The podocytes.
Yeah. Here we have more RBCs. So this is the capillary space, the basement membrane. It looks a little thin to me.
Okay.
I'm sure
we'll get a
we'll
measurement
have
on the next screen.
Yeah. But yeah, more foot process effacement all the way around.
Yeah. Good. Yeah, and on the capillary over at 9 o'clock as well. That one too.
Yeah, over here too.
Yeah.
200 nanometers for the basement membrane should be 350.
Well, the normal is 300 to 500.
300 to 500.
Diffuse, the literature says diffusely less than 250 is consistent with thin basement membrane disease.
So that would explain the hematuria that she had on her UA.
Yeah. And then here you have a good view of the podocytes. At high power. Yeah, you could really see there's no slit diaphragms between them. They're all diffusely effaced.
Yeah, that looks good.
Yeah.
So we've got minimal change disease with pretty significant ATN and thin basement membrane disease.
Yeah, good for us.
Yeah, really.
Thank you.
Beautiful pictures, David, and nice read for us. I'd like to point out that Dr. Rubin doesn't need EM's measurements. He picked up on the thin basement membrane disease with his own eyes. So, well, that explains hematuria. And Sarah brought that up, the possibility of, you wonder how many of these patients could have thin basement membrane disease. So that at least it fits in a lot of ways, and the hematuria is now explained. Before we hear anything more about this case, let me ask a couple of clinicians what they would do. Dr. Rubin, how would you treat this patient?
The name of the drug is corticosteroid. I will obviously look for collagen 4 abnormalities as well. But yeah, I mean, I would treat this patient with steroids plus PGP prophylaxis.
And you would obviously look for because of the thin basement membrane?
Yeah. So when I see thin basement membranes on EM, I always order the type 4 collagen stains, the alpha chains, and they were normal in this patient.
The reason I asked Mario was because it's a second diagnosis that I don't know has any clinical relevance, but I guess David did it anyway. Do you think it has clinical relevance?
Well, with a negative result, no, but clearly during the discussion that you spearheaded, I mean, the issue of hematuria in the setting of minimal change was really unexplained for the most part. So there are these changes now that suggested that there may be something else in addition to the podocytopathy.
No, you're absolutely right. I was just wondering, if knowing that it's thin basement membrane disease, does that change anything as far as the therapeutics of this case? I guess that's what I was getting at. Yeah. So, Dr. Suki, Dr. Rubin said corticosteroids and about a 15-second lapse in silence because it was so obvious to him that that's the treatment. That's the only treatment. How would you treat this patient? Dr. Suki, you still on?
Go ahead. Yes, I agree with the corticosteroids, but also with a strong emphasis on antimicrobial prophylaxis.
Meaning,
for example, Bactrim double strength.
Mm-hmm. Yeah, that's a really good point. Sometimes we don't talk about that. Well, would you treat this patient with, knowing what she has and knowing you're going to give her steroids? Would you treat her with and her cholesterol is 400? Would you treat her with a statin?
I was going to have a question about anticoagulating this lady. Her albumin was down to 1.4. And if we abide by the rule that when it gets to below 2, you should anticoagulate, I think it would be important to strongly consider that in this young lady. As far as anti-lipid agents, I think that would be in order. I don't see the downside.
Dick, would you give this patient statin, and would you anticoagulate, knowing it's minimal change in the natural history of response?
Well,
I would probably lean towards anticoagulation and not adding a statin, because the evidence that treatment with a statin will help in any way protect this patient from cardiovascular disease is absent. And why add another drug when it's not known to be efficacious? I understand the temptation to treat an LDL of this magnitude, but if she really has minimal change disease, the likelihood is that it's going to be a short-lived disorder, and it will probably respond quickly to steroids. But I don't see any urgency to starting a statin, but I see a great deal more urgency to start the patient on anticoagulants.
So can I break in at this point, or is this a problem now?
No.
All right, so no, that's an interesting concept, and I've actually asked Brad Robin about this recently because he's doing the new KDIGO guidelines, and the whole issue of starting ACEs and ARBs or statins and even anticoagulation in people with minimal change disease is somewhat more up in the air because they do respond a lot more quickly. I mean, for years, I'm sure most of us didn't start anticoagulation in these patients, and so I think that's an important issue because I think if this is the, I think even the guidelines that I've looked at, and that's why I called Brad, they still don't really make any recommendations in minimal change disease about the use. In fact, actually, Dick, you wrote the guidelines on nephrotic syndrome, and I think he kind of deferred to you on this. So is the issue, in these patients that say in general, I know adults respond slower than children, but since they do respond more quickly, would you still kind of across the board anticoagulate in particular patients with minimal change disease who more often than not are going to have albumins less than 2, let alone, I think the old standard was, well, 2 is kind of what we used to use. And then I think after kind of the more recent papers from Chapel Hill and Toronto, I think 2.8 was the break point. Would you still anticoagulate these patients?
Well, Steve, this is a tough question. And in my case, it's undoubtedly influenced by prior experience. I've had some disasters with minimal change disease and abrupt, very severe nephrotic syndrome with serum albumins in the 1 to 2 range, 1 to 1.5 range, with clots and pulmonary emboli. So I tend to be more aggressive, and that's conditioned by prior experience. The data is that in minimal change disease, the highest risk for DVT and pulmonary emboli is within the first 2 months after the diagnosis, and it is particularly seen in patients with a combination of severe hypoalbuminemia and high urinary protein excretion. I understand there's no randomized controlled trials, and the data that's been accumulated is largely in membranous nephropathy, but I have a lot of respect for the possibility of a catastrophic venous thromboembolic event even arterial thrombotic events, although that's more often seen in young children. So I would anticoagulate prophylactically.
So what about putting them on aspirin? Would that be a second best or no?
No.
Well, no evidence. I would probably go for full prophylactic anticoagulation.
Yeah. And if I may interject, I think you briefly mentioned this patient is 23 years old. This is not a child with minimal change.
Right.
So she may not respond as briskly as you think she might. And I think to risk a thrombotic process due to a slow response, I think may be hazardous.
I mean, it's a good point, but Stuart Cameron and Nolasco was I think the first author of the paper, and even in our experience when we published it's been a long time ago. People under the age of 45 still respond faster than patients over the age of 45, and she's closer to she's on the lower end of the spectrum. So I agree with you. I understand that adults respond slower, but younger adults still respond a little faster than older adults would.
I'm going to butt in here. Bill's got some discussion for us and some follow-up. So Dr. Whittier, you want to take it back? A great discussion, by the way. Thank you.
Okay, hopefully everybody can see my slides here. So this is what we did. Hold on. Yeah, so we put her on prednisone 60 in addition to Bactrim. We did not anticoagulate her. She saw her internist afterwards who started statin without me knowing. And she had a very rapid response. She went from over 12 grams of proteinuria. Within about 3 to 4 weeks, she was down to basically non-existent proteinuria, and not surprising, her albumin came up and stayed steady. We did about a what was it, about a 4-month taper after, we continued for after she was in remission. We continued high dose prednisone for I think it was 4 weeks, and then we started about a 4-month taper, and she did pretty well after that. So from the end of December until actually it was in April, when she noticed that her urine was frothy again, her shoes couldn't fit again, and she said, "Oh no, it's coming back." And so she was right. The proteinuria jacked up again. The albuminuria dropped, or the serum albumin dropped again. So the question then was what to do at that point. I think, Pravir, you may have a poll here. If you're a host and you're able to speak right now, then do not answer the poll because it'll go away. So this poll is for hosting people on the Zoom. So how would we treat right now? Prednisone alone, prednisone with Cytoxan, prednisone with tacrolimus, prednisone with Rituxan, or lower dose prednisone with Cytoxan.
Give it a little time here. Please vote, and we don't know what you're voting. No one will be called out. Still votes still coming in. Got a nice number of votes. Wait
it's such a good point too about Bactrim, and that 15, 20 years ago, I think we were using it on the long-term prednisone and lupus and people that are on Cytoxan, and now basically anybody that's on over 20 milligrams of prednisone for over 2 weeks is getting Bactrim in my mind. And I keep it on until they get less than 20 milligrams. PCP is pretty devastating.
That's from the room literature recommendations. So here's our answers. Here's our poll. 45% said prednisone looks like alone with a slow taper. 14% said prednisone with Cytoxan. 10% said prednisone with a CNI. 28% said prednisone now plus Rituxan. So the two biggest are just prednisone, treating like the first time. And the second most common response was giving prednisone with Rituxan now. So Bill, why don't you walk us through what you did and what your thoughts are about this?
Sure. So let's see if I can get rid of the poll here. So when Dr. Corbett and I wrote this article, if you want to look it up, it's basically one word: corticosteroids. Pause 15 seconds. But yes, of course, steroids I think is really routinely in for first line. But there's several nuances that can occur in this disease with relapsing and so on. But even the steroids as first line therapy isn't pure. So there are some studies that have looked at treatment of de novo minimal change disease, so right out of the bat with other agents besides steroids, which is particularly important to our patients who really do need to avoid steroids for whatever the reason. This study randomized patients to TAC versus prednisone, and they basically had a relatively equal remission in both groups, okay? And there was a relatively equal relapse rate. So without steroids and tacrolimus alone, it led to about the same amount of remissions and about the same amount of relapses for the first relapse. So there is options other than steroids. And this study also looked at, instead of tacrolimus alone, it looked at tacrolimus with low dose steroids compared to high dose steroids alone, in about the same situation where they induced remission at about 80%, which is relatively standard. And there were actually less relapses in the tacrolimus and low dose steroid group. So again, these are relatively newer articles. This one was in 2021, but there are options for those patients. But the tried and true really is steroids alone for the first exacerbation, minimal change. But again, 50 to 75% of these patients are going to have a relapse, and the standard there is certainly, according to KDOGI guidelines and the rest of the literature, is to hit them again with prednisone alone. Sometimes CNI can be added to minimize the steroid dose, and there's been another study on first relapsers with combined, I think it was cyclosporin, but it might have been tacrolimus and lower dose prednisone to induce remission. And then some of these patients become frequently relapsing or steroid dependent, and that's particularly devastating because this long-term side effects of steroids can build up pretty quickly in some of these young patients, especially when they're young like this. and frequently relapsing and steroid dependent is around 25 to 30% of patients. And the definition is pretty significant amount of flares. I mean, greater than 2 relapses in 6 months is pretty frequent, and greater than 4 relapses in 12 months, or 2 relapses with the steroid taper, or within 2 to 4 weeks of the taper. So that's kind of the definitions of the frequently relapsing and steroid dependent, and both of those are treated the same. I mean, this is from KDIGO 2020, where you have your frequently relapsing, and that is not this patient, right? Where this patient is a one-time relapse, where we are with her right now. But if you get into this frequently relapsing or steroid dependent realm, then cyclophosphamide is really the treatment of choice if there's no issues with patient preference. But other agents have been used, including rituximab, CNIs, and MMF. But I think that the 2 big favorites out there are cyclophosphamide and Rituxan for treatment of this FRSD minimal change. So this is typically what's done when you're in that realm. So it's high dose prednisone again, plus Cytoxan. We use oral Cytoxan for 2 to 3 months, and that's at a dose of 2 mg per kg. In Rituxan, there have been different dosing regimens studied. The one that I use for almost all of my patients is 1 gram separated 2 weeks apart, although people could use a 375 one as well. And actually the studies, even though this is really more tried and true and has a lot more longevity with Cytoxan, the studies show about equal remission rates and relapse rates for the frequently relapsing or steroid dependent with these 2 agents. And so they're, in my mind, interchangeable. Now, the real question though is should we add it early, and should we add this at people's first relapse? And then also, I think there's a huge question out there about maintenance. And so this question is largely unanswered. I could only find one active study that looked at hitting patients with other than steroids at a first relapse, and that was used with CNI, and they still ended up getting quite a bit of steroids even in the CNI group. So there's not a good randomized controlled trial to add Cytoxan or Rituxan on at first relapse, because it could be an infrequent relapser. So if they're going to keep relapsing all the time, though, you're going to wish that you have treated them with Cytoxan or Rituxan earlier. And so what's the literature on that? How often are these patients relapsing, and how often are they transitioning from a frequent relapse to or from an infrequent relapse to a steroid dependent or frequent relapser? And so this study really, I think, gave quite a bit of insight into that question, which is how many of these patients relapse, continuing to relapse. So all the patients in this group got corticosteroids. Again, it was a pretty young population. It's all patients with a minimal change disease. And what happened was 93 in the patients of the 125 with steroids were successful at reducing admission, but 61% of those patients relapsed. Okay, and then of those, they did what they're supposed to do according to KDIGO guidelines, which is give them steroids again. And of those, 56% relapsed again. So it does seem that there is this population out there that's really going to continue to relapse over and over again. And minimal change is, as much as we think it's benign disease, as Dr. Glassick was pointing out, there's complications. There's thromboembolism, there's AKI. 60% of patients had no AKI, but 40% of patients had AKI with minimal change disease. So it's not as benign as we think it is. All sorts of infectious complications, including peritonitis that Dr. Glassick pointed out. And look at this, death in young people with minimal change. This is just horrific and scary. And here's the thromboembolic situation in patients with minimal change disease. So it's not as benign as we think it is. We always think it's so benign because it very rarely leads to end-stage renal disease. But if a patient relapses and has a severe relapse with acute kidney injury or a thromboembolism, then it's really worthwhile to consider hitting them earlier, maybe even at the time of their first relapse, with something other than or in addition to prednisone alone. And this patient, when she came back in with her first relapse, did have AKI as well. Remember, she had that severe hyponatremia, and she had that again, but this time she also had AKI with it. So again, not as benign as we think. And so what we decided to do in our patient is actually give prednisone and Rituxan. And the prednisone itself was likely what induced her remission this time, and that's what happened here. And then we got her a second dose of Rituxan. which is really not what, KDIGO suggests. You're really supposed to hit them with prednisone alone here. But I think there should be some consideration knowing the relapse rate after the first relapser to do something like this a little bit earlier. And I certainly think that this is an area that requires active study.
Great, Bill. That's really, really interesting.
Roger?
Really nice slides. Yes, Dick.
While you've got this figure up, I think it is important to pay attention to the length of high-dose steroid treatment after the manifestation of a complete remission. Both KDIGO recommendations in children and adults state that this should be at least 4 weeks after the complete remission, 1 month. I can't clearly see, but the patient was started on a prednisone taper at about the same time that the complete remission was documented. This may have played a role in the early relapse, because I think too often we tend to initiate the steroid reduction program at the time of documentation of the remission. KDIGO clearly says that that's not probably what should be done, in that they recommend at least 4 weeks of continued high-dose steroids after the complete remission.
Yeah, thanks for bringing that up, Dick. In this case, it's not very clear on here, and I'm sorry about that, but we did wait 4 weeks before we started the taper, and she was in complete remission so quickly. But you're right. Actually, this chart's not even that great because I forgot to put the month of May on it. so it really, the timing is not. I just noticed that now. I was like, wait a second, because there was even an extra month here of that. But your point is a very good one. And interestingly, I was looking at that in this study where they actually, in this study where it was for de novo treatment with tacrolimus and low-dose steroids versus high-dose steroids alone, they actually only started their treatment phase or the remission phase and started tapering 2 weeks post-remission. And so I thought that was also very interesting, realizing that I really think that they should have done a 4-week post-remission before they start their tapering of the different medications. But she fortunately so far is now in complete remission, but the goal, the time will tell to see if she's going to become a frequent relapser or not. And I'm hoping, although I don't know this, that I'm hoping Rituxan might minimize that.
Well, this was really the crux to this case to me, is that, should we change how we think about this? Since, what Dr. Whittier pointed out, a large percent of these patients will have a second relapse. And do you wait for that before you go ahead and give Rituxan or cyclophosphamide for that matter? Because it's not a benign disease, as he pointed out. Dick, I mean, how strongly do you feel about this? Would you have treated this patient the way Dr. Whittier did?
Well, thank you for asking, Roger, but I think I probably would have treated the first relapse with steroids alone and a somewhat longer tapering period. But I can't disagree with use of rituximab, although I would like to see more data to support that idea. The question is, will it prevent later relapses? We don't know.
Yeah, well, it certainly seems to prevent other relapses. I mean, that's one of the real effective means of changing somebody from steroid dependent or steroid frequently relapsing. But like as your words are, this is a data-free zone, so we don't really know. But
Roger,
I think
what do you think about in those that you do use Rituxan, or if they are frequently relapsing, or if you decide to do it after they're onto their first relapse, what do you think about maintenance Rituxan for patients to keep them in remission?
That's a really good question, and because I've gotten different opinions on that. I had a patient exactly like this that went up to a certain very large medical center in Minnesota, and saw a very famous nephrologist who does a lot of this in Minnesota. And they will give Rituxan then every 6 months for 3 years, I believe. So 6 doses. And that was a completely new idea to me as that kind of a chronic, which I don't think has been studied, but they feel very strongly. And his wording is that a minimal change disease is a chronic condition. You'll always have it. It's just a matter of when it's going to come back. And so he thought you should treat for very long. I have not done that. What that has done for me though is that when I've given Rituxan for frequently relapsing minimal change, I've given 1 or 2 extra doses in 6 months, but I haven't gone as far as 3 years. Does anybody else have any strong feelings about that?
I think it's very interesting because the ones that and this is anecdotal, which again is evidence-free zone, but the ones that I've given Cytoxan to have induced remission for as long as I've been a nephrologist. I mean, these people are coming back 15, 20 years after their Cytoxan when they were a frequently relapsing patient, and they haven't had a drop of, the protein's been undetectable forever. So it's funny, at least it seems in my mind that Cytoxan is quite effective at turning it off for good, and there was no maintenance there either. Rituxan may be different though.
Dick, what are your thoughts about that? Do you think that, I mean, I know it's an evidence-free zone. Rituxan is so popular now. You want to use it for, wait, I'll speak for Bill and I. We want to use it for everything as opposed to cyclophosphamide. We have this feeling it's safer, it's easy, it's one time, you're not following white counts, you're not worried about bladder issues, blah, blah, blah. But there's more and more evidence now that maybe cyclophosphamide is getting a little, not the respect it deserves. Certainly for membranous, it's probably a little bit better, and for some of these severe, it might, maybe it lasts longer. Dick, what do you think about that?
Well, Roger, again, I don't know how effective it is in terms of duration of remission with a direct head-to-head comparison of cyclophosphamide versus rituximab. I wish we had that data in adults, but I don't think we do, at least for the long term. But a frequently relapsing patient who is steroid toxic from repeated administration of steroids is certainly a candidate for either cyclophosphamide or rituximab. And the choice now depends largely on how much the patient is willing to tolerate in terms of side effects. I don't know about your patients, but when I mention cyclophosphamide to a patient and describe the side effects, and then I describe rituximab and the side effects, the choice tends to be for rituximab rather than cyclophosphamide.
Yeah, that's absolutely the case. And certainly in a young woman like this, I think it's even stronger, although probably a few months of cyclophosphamide would have a very low risk of infertility, but it's still there. And I think we all feel, without as much data to support it, that it's probably safer, but even without the side effects, it's probably safer. But that's kind of the way we've been moving. So I'm really, I'm glad we had this discussion because I think it's a really important discussion. As Dr. Glassick pointed out, I wish we had more data to know exactly what to do. But, at least for everyone in the audience, just, think about your timing, think about what you're giving, think about how many times you're going to wait before you give them something more definitive, and really think about the long-term side effects of all these steroids. It's not benign, and the risk of, it's not just another relapse that might go away in 4 weeks. In that paper that Dr. Whittier showed, when they treated the group with steroids for their first relapse, they all went into remission within 4 weeks. So yeah, it seems like it's a fast remission, but then you got to go another month before you taper, and your taper's slow, and steroids are not benign. Each time you give a long course of steroids, you're going to risk osteonecrosis. So I'm a big fan of this earlier, more definitive treatment, even though there may not be the data for it. If I had to guess and I had to do it, that's what I would do. Again, realizing there might not be data, but I'm glad you did that, Bill. And I think you did a great discussion about that. I think we'll wrap this up. We've hit the hour. Thanks everybody. This was really, really wonderful talk. I appreciate everybody's contributions, and Steve for checking in from Paris. And everyone that contributed. The activity code is 482942. This was recorded. It will be available on YouTube shortly. We probably will be here next week, but just keep your eyes open for our emails. And thanks everybody, and stay safe.